PoCoG preventive interest group. Joe and Bonnie from the PoCoG office are webinar pros, so they will help us with all the proceedings. So Bonnie, do you want to say a few words with regards to how webinars work and how we'll handle the discussion?
Hi everybody, I'm sure you are very well versed in the practice of webinars by now, but this is actually a Zoom meeting rather than a webinar, so we ask that you keep your microphones off and your cameras off, just so that we can keep the focus on our panelists, and use our chat function to ask any questions or make any comments. Joe Shaw, the Executive Director of the PoCoG office, will be moderating those questions, and we'll be answering those at the end of the meeting today. So it's probably about all the housekeeping, Monica.
Okay, great. Thank you. So it's my great pleasure to welcome you today to this webinar, and I would like to introduce to you Professor Christine Paul from Newcastle, who is going to host this meeting and also be one of our speakers. And we also have three other distinguished speakers who we will hear from today. Kylie Vuong, who is a GP in general practice and also a researcher at the University of New South Wales. Craig Sinclair, who of course is one of the most eminent policy advisors in the cancer space in Australia. And we also have Amy Pern, who is a genetic counselor and works in clinical practice and has a lot of experience in telehealth and doing counseling online. So thank you very much to all these speakers for spending the time with us today. Before I go to the speakers, I would just like to introduce our prevention special interest group just ever so slightly. So if I can just share my screen and make a little bit of some of you aware of our group who might not have heard about it. Some of you may already, actually the right one. So stop share again. Where is it? Wrong one. No, it's not working. Okay, so I will stop share and I will just talk you through our interest group, except if Bonnie can open it from her screen. So basically our special interest group within PoCoG is to enhance the integration of prevention into psycho-oncology research and practice. And we really want to foster the health and well-being of individuals, community, and society. And this special interest group, oh, thank you very much, Bonnie. If you just scroll down a little bit to our principles and vision, which I'm just talking you through. So PoCoG, of course, is a leader in interventions in supportive care, but we also want to use the strengths of the group to also focus on prevention. And some of you might know this, this diagram by Rosberger et al. On the role of prevention in psycho-oncology, which was published a few years ago, which we want to reactivate and modernize as one of our aims pretty soon. We've set ourselves 6 KPIs for 2020. So Bonnie, if you scroll down maybe to that, to those KPIs. And some of those are actually what we are doing today to get the discussion going on psycho-oncology and how the preventive focus can become more prominent in that field. We want to do that through workshops and publications, outreach and networking. We want to have a specific focus, of course, on the prevention of comorbidities, adverse events, and subsequent cancer in those people who already have a first cancer diagnosed. And as we all know, mental health is particularly important for primary, secondary, and tertiary prevention uptake. We also want to support research that advances the approaches to cancer prevention and cancer treatment side effects. We want to develop some new and better measures. And we want to work together effectively with other groups that are doing amazing advocacy, such as the cancer councils, and try to contribute to spreading the word how important prevention is. So these are our KPIs. So if you're interested in that topic and you're not yet part of our group, please feel free to join us. And Bonnie is sending out the agenda and links to our regular meetings that are also held online, such as today. So moving on, I guess, to the topic of today, as most of you would be aware, the COVID situation has had a major impact on cancer prevention and early detection behaviors that are going on. And there have been both positive and negative impacts. And some of those that you might have heard about is that some cancer screening services have had to delay intake. There has been, of course, a massive reduction in people presenting to general practitioners for signs and symptoms of cancer that they might otherwise have been doing much more rapidly. There has been a lot of impact of COVID on mental health, and as we know, mental health again then is one of the determining causes of whether or not people will seek cancer prevention and early detection services. And for cancer patients, of course, it's extremely difficult to navigate the current scene. But then there have been positive things as well, such as people have been going out much more for walking and cycling, lifestyle changes, such as connecting again with hobbies and things that might have fallen apart because everyone was working so hard before COVID have increased. And so there has also been a number of positives. And so we thought today we'll talk a little bit about that, hear from people in policy and practice, and also research on how all these issues have evolved, and then hear from you a little bit more about how you are dealing with all of these and how you see cancer prevention can maybe benefit from the current COVID crisis. So without further ado, I would now like to introduce our first speaker for today. So as I mentioned, Kylie is a senior lecturer with School of Public Health and Community Medicine at UNSW, but she's also a general practitioner working clinically in a part-time capacity. So she wears 2 or more hats on a daily basis, apart from also being the mother of young children, which of course means that she has had to deal with all kinds of homeschooling and so on over the past few months. So Kylie, the general practitioners are essential in cancer prevention and early detection and also supportive care activities. So I was wondering if you could reflect a little bit maybe on what you have been hearing from your GP colleagues, how COVID has impacted on preventive activities.
General practice, thanks Monica. General practice has seen quite huge changes recently with COVID, and very quickly we moved from seeing all of our patients face-to-face to some practices running most of the consultation either online or over the phone. This is mainly to protect the patients and also to protect ourselves and our practice staff. Now, the telehealth consultations we have seen have worked very well in that it has helped to triage patients. Some patients can certainly have their problems managed online, managed over the phone. Some patients have had to come in. Some patients, after having a chat to them on the phone or online, they don't have to come in. So we've minimised the number of people who have had to come in. But certainly a lot of the consultations have focused on the acute, not so much the chronic care. We've seen a reduction in that. Cancer screening, that has gone down.
So what do you think, Kylie? You mentioned that especially the care for people with chronic diseases has gone down. So that's sort of the tertiary prevention that you're mentioning there. how can you support people who might have had a cancer in the past and maybe detect recurrences and so on. What do you think? How could that be improved again in the general practice setting?
We have seen an improvement already, in that we are encouraging a lot of our patients to come back. And the RACGP has had a recent campaign to welcome patients back to practices. General practices, most of them are privately owned, they run as small businesses. So in many ways, they're quite agile, and that's something that it's a strength. So many have adapted to their patient populations for cancer patients or people who are vulnerable with other risk factors. We have been able to find times for them to come in when it's generally quieter and have them space out. Other practices are having patients wait outside, sometimes in the car, sometimes just space outside the surgery, so that they are appropriately socially distanced and not in crowded waiting rooms like they were before.
Yeah. Mm-hmm. With the teleconsultations, Kylie, do you think there's opportunity to improve services that have been given to patients?
Telehealth consults, many of them are done over the video and video platforms. For some surgeries, though, most of them are done over the phone. It is quite different doing consultation using telehealth compared to in person. There are nuances in person. There's certainly body language that we usually pick up when someone is in our consultation room that we don't pick up when the consultation is done over the phone or over video. So it's not equivalent to what we usually do. There may be ways to optimize it. As we all get more comfortable delivering care in this way, I think we would all be a bit more forthcoming, but certainly it's very difficult running a consultation over the phone. We are scenario testing, we don't see the person, we don't want to miss anything serious. So sometimes as a clinician, we think the worst. We ask a few more questions, and then it is a matter of assessing what is the threshold for bringing a person in based on what information we've got and what is the risk to that person coming in sometimes as well. What costs are they coming in from afar? How easy is it for the patient to come in?
Yeah, okay, great. You mentioned the mental health of cancer survivors, Kylie, and some who are particularly anxious now with regards to COVID and how it might restrict their access to the oncology care. What's your reflection on how maybe the psycho-oncology practitioners could also assist the GPs in overcoming those mental health issues?
I think there's been quite a lot of anxieties around the population in general. Yes, some of it is around cancer survivors, but in general, there's been a rise in mental health issues, the isolation, the lockdown, the changes, and financial stresses is having an impact on people. I think we see people come in, but the people that we see come in may not be representative of the general population because it has to reach a certain threshold for people to then make a phone call and come in to see their GPs already. Compared to what might be happening, we are seeing people who are a little bit more severe already. So I think that definitely if we can get a bit more support and reach out to people, that would help.
Yeah. Mm-hmm. So I think PoCoG is doing some survey work to understand all of the impacts of COVID better, and Joe might speak a little bit about that later on. And I guess PoCoG is also a leader in self-management interventions. And so I think what you're just mentioning there, Kylie, might give some clues for additional supportive interventions that might be needed in the future. That's really, really great. Thank you. So Kylie, just personally to wrap up, how have you coped with the restrictions and what has it meant for you also as on the research side?
Personally, for me, as a GP, as a researcher, as a GP, definitely we take a risk when we go into clinical practice. I think all doctors at some point have fallen sick or caught something from their patients. Certainly COVID has made me think, oh, what is the risk for me as a GP going in, and the risk for my families as well, because we all come home to children, and so it's sort of made me reassess what I do and how I go about it to protect myself, my patients, the practice staff. As a researcher, found things have slowed down a bit. Not being able to go in face-to-face, and in general practice research, some of the recruitment has been in general practice waiting rooms. Now, these general practice waiting rooms are socially distanced spaces to keep the patient and the practice staff safe. How do we go about recruiting in the traditional way? And there's been quite a lot of changes in general practice, just changing work about, how care is delivered. Very quickly, we've had to put in systems, telehealth consultations, face-to-face consultations, billing systems, how to follow up people. All of that is a bit of an unknown. How is that going to pan out in terms of outcomes for the patient is a bit of an unknown as well. So there are certainly opportunities, I think, now to understand, reflect, and make sense of what has happened. And it's an evolving space. Things are still changing. And looking at the numbers, general practice might change again when we are started to relax a bit more ourselves. We might need to be a bit more vigilant now. Lots
so very
of things.
interesting. Yeah, you're suggesting quite a big research agenda that PoCoG and also PC4, I guess the GP clinical trials group could pick up on there. So thanks very much, Kylie. And please feel free to also ask questions from the other speakers as I move on now to Amy Pern. Amy is a certified genetic counselor. And she works and runs the Gene Council from Western Australia. And so, Amy, can I again start with asking you, you're currently on mute, so maybe if you unmute first, Amy. And then can I please ask you a little bit about how COVID has affected your practice?
Thanks, Monica. And I'll maybe just mention for anybody who hasn't worked with genetic counselors before, the role that I play is to meet with people who have a personal or family history of cancer to discuss the hereditary cancer risks and coordinate genetic testing where that can add to the picture. And prevention is a big part of what we do. Even for people who've had cancer, we might be looking at prevention of other cancers down the track. It's been interesting for me because I set up my practice a year and a half ago to be primarily by telehealth, to provide better accessibility, especially in WA where we're so spread out, and also to be able to provide a better value service for my clients without keeping the costs to them to a minimum as well, because it can be a costly exercise sometimes. And so it didn't, the day-to-day sort of practicalities of how I do my work didn't change, but I said for both my clients and for my colleagues, the business of life got a lot more complicated. I have to say we're very lucky here in where we sit at the moment with COVID. And I've found with things starting to settle down a bit, I've had a lot of clients come out of the woodwork who had been putting off testing or putting off appointments, who are perhaps finding they're ready to take up more proactive behaviors of thinking more about their health and more about prevention and ready to take that next step now. So that was interesting for me, and also continued seeing my clients the whole way through, and was meeting with a lot of people who their cancer treatment plan had changed, or their access to a routine follow-up appointment had changed. And although I think they were frustrated, there was a great deal of resilience there that I think I was expecting people to be a bit less resilient to that. And there was an understanding of this being something that we can't control and can't change. Having said that, that frustration and that anxiety is definitely still there about not being able to access those appointments or having to shift things around or having uncertainty about how things were going to be managed. So yeah, it's been interesting to see how now that things here are a bit closer to normal, but a different normal, definitely, that people are taking some of those steps to take better care of their health for future.
So that's really interesting, Amy. You said that people were coming suddenly contacting you unexpectedly. So what do you think what happened? Was it that delay in, or who are your referrers and what?
So my primary referrers are generally specialists in the cancer space who are seeing people who either have cancer or who have a strong family history and are needing extra screening to try and help clarify the risks. So primarily breast cancer, because it's so common, would be my biggest referral pool, from breast specialists, breast surgeons, and that sort of thing. And the people who seemed to kind of come out of the woodwork were people who'd been referred and either had other things on their plate, family, life, general things. A lot of the kind of not cancer affected people who thought, yeah, I'd like to know a bit more, but had sort of other things had taken priority along the way. And I suspect, given that there was a big chunk of time that we all had to be at home more often, and there was some less to do until everyone figured out how to have dinner parties on Zoom, that people had time to sort of reset and reevaluate and reset some priorities and do a bit of, I guess, physical and psychological housekeeping and go, this is something I really need to cross off the list and take care of. And so, yeah, now that it's a sort of a bit back to normal, they've found the time to do that.
Yeah.
So I don't know if it'll be that same kind of delay in other states where it might take a bit of time for things to settle a bit more, and then people will feel comfortable coming forward for care and perhaps more proactive about it as well.
Yeah, interesting. So you actually observed quite a few positive impacts of COVID, and that's really crucial. So given what Kylie just said with regards to the telehealth activities that GP practices had to adapt really rapidly to, and you doing this as actually your main way of providing services, Amy, what would you say? What are the learnings maybe that you you think could be coming out of this?
So even though I've been primarily telehealth for the last year and a half, I've worked a lot with telehealth over my career. I've worked in a lot of places where we've got a lot of remote and rural populations in Canada and here in New Zealand. And I know in the public health system, telehealth has been around for a really long time, but it's kind of a last resort. And that's changed very quickly. And I think that's been a real challenge for a lot of people because of the speed of that change. Because I hear, and I definitely recognize and acknowledge the challenges in working with telehealth, but I think there are some great benefits that can outweigh some of those limitations, and the limitations get less the more we as providers practice using it. The more comfortable we are and the more confident we are, the more we find better ways of dealing with some of the lack of visual cues and picking up better on context when dealing with somebody by video. And even 15 years ago when it was by phone, I was involved in some research of phone genetic counseling and some video in British Columbia, and clients and patients love it. The satisfaction levels were lower in providers, but clients absolutely love the convenience, the accessibility. I think it's got huge potential for dealing with rural and remote clients, or in my case, a lot of times people are in mid-cancer treatment. They've got 900 other appointments, or are post-treatment and have a lot of anxiety about returning to a hospital or a clinical space to have an appointment that doesn't require me to examine them physically. So that's quite different to you, Kylie, in that I don't have any role in examining a patient physically. So that's a bit different. But definitely where it's appropriate, I think there's a huge potential to benefit patients in equitable access to service. Yeah,
really increasing the equity across Australia if services are accessible in this way. Really,
and COVID's really forced, I guess, services and also providers of telehealth and your client management software and everything to really get on board. So there's more and more resource and more capability to do that as well. So even though I was already doing things by telehealth, I found a lot of things have been put in place to make that easier, more straightforward for me and for my clients as well.
Yeah, perfect. Well, thank you very much, Amy, for sharing your experience, and it's wonderful to see how well that all works. And I guess it's reassuring that you now feel very comfortable with it after doing it for a few years. So hopefully other providers will follow suit, and the satisfaction of the providers will increase as well. Yeah. If they can see that they do a really good job in the video conferencing. Thank you, Amy. Thanks. Can I move on to our next speaker now, Professor Craig Sinclair, Head of Cancer Council Victoria's Prevention Division and Director, World Health Organization Collaborative. So Craig, thank you very much for coming to speak to us today. And I would really call on you from the perspective of a policy specialist. What are your observations on how cancer preventive services have been affected by COVID? So obviously there was a big win this week with regards to the alcohol labels that have been endorsed, but what other changes have you observed, Craig? Oh, you must be still on mute.
Sorry, I was first to stuff up. Look, certainly I'll talk on the alcohol, but before I do, I think it's worth just continuing the bit of a theme around cancer screening and what we've been seeing that we all have already talked about, a reduction in GP visitations. Cancer Australia did a really nice analysis just very recently, and they said if 1 in 10 Australians delayed seeing their doctor with a cancer symptom, so 1 in 10, and I think that would be a conservative scenario, and they delayed seeing their GP for 6 months. I mean, this could impact potentially 7,000 cancer cases going undiagnosed, which really does suggest the impact this will have over the longer term as people will be presenting with much later stage cancers. Our own cancer registry here in Victoria has been monitoring breast cancer incidents, and just in the months of April and May of this year, they saw a 37% reduction in breast cancer incidents. So from a population perspective, we are going to see a big impact on screening rates, and we could potentially see opportunity in terms of governments needing to invest to improve cancer screening as we come out of this COVID-19 circumstance. The challenge, of course, is if people are getting being detected with early signs of cancer, even getting into getting into hospitals for treatment for colonoscopies and colposcopies, for example, will be delayed. On a much broader policy perspective, going back to your question, we have some real issues, and certainly in relation to alcohol, FARE, which is the Foundation for Alcohol Research and Education based in the ACT, they found that 70% of Australian adults are drinking more now as a result of these pandemic circumstances than what they were doing before, and 1/3 of Australians are drinking daily. So we've got some really unhealthy habits here forming, which are going to be making it much harder to unravel as we come out the other side. In relation to smoking, we aren't seeing and detecting necessarily any change in smoking habits. We haven't been able to pick that up. In the United Kingdom, they've seen a reduction in smoking, daily smoking, as a result of the pandemic, but they were locked down for a longer period than what we have. With our calls to the quit line have certainly gone up. I think one of the real challenges for this from a policy perspective is that, and we saw this played out very recently in relation to the pregnancy warning labels that fortunately did end up getting through, as most of you would know. But the greatest industry argument to counter the pregnancy warning labels was the cost to industry. And this issue was really resonating within the context of COVID-19. And I think politicians are particularly sensitive to this. And the same argument was sort of played out, not to the same degree, around health star ratings, which is also under consideration at the moment, cost to industry. It is definitely an argument that's been used in this context previously. But as we go along and looking at some of the other policy measures, such as sugar sweetened beverage taxes, if we look at volumetric tax for alcohol, this argument is going to resonate more and more with politicians, which will mean that there'll be a much greater reluctance for policy change if it comes at a cost to industry. And I think we're going to be living with this for quite a number of years now. There are some opportunities, and as I mentioned, I think we will see, when the data starts coming through from the national registries, with the reduction in participation in national screening programs, we will see the government wanting to invest. I expect that they will be doing this. Certainly the signals we're getting is that they will be doing that to try and improve cancer screening rates up to at least pre-pandemic levels. And I think governments, the other challenge, of course, is that governments aren't going to have the same amount of money to invest in public education. They're going to be looking at policy changes which are at low cost. So we'll see how that plays out. But I think it's going to be really difficult, not so much for this year while they know what they have to do, but 2 to 3 years' time, when some of the major public education contracts up for renewal, the cupboard's going to look pretty bare, and it will be really difficult for agencies like the cancer councils to be able to position themselves to at least sustain the sort of efforts that we've been involved in going previously. If this pandemic's taught us anything, it's taught us the importance of maintaining a healthy population. It's also taught us the power of public policy in influencing behaviour, and I think there will be some real lessons coming out of this.
Absolutely. Yeah, it's really interesting what you just said, Craig, that because we know how important policy is and that it's often the most effective way to achieve good preventive behaviors of the population. If you think that might be impacted, does that mean then for our psycho-oncology counselors or other counselors or behavioral interventionists that helping people to make personally healthy decisions could become also more important?
Yeah, that's a really, really good point, Monica. And I think the opportunity going forward is around system reform. So it's much easier for practitioners in managing their clients or patients to be able to, for example, make referrals to the quit line and know and be assured that that will be followed up. Looking at how interventions in GP practices or even in the hospital settings, how interventions could also check in on their screening status and even recommending opportunities for screening. So it's around those teachable moments, and I think the role of physicians, psychologists, clinicians, if we can get system reform and the right processes in place, looking at how we can use the system to enhance screening will be an important outcome coming out of this. So I think that is certainly the opportunity going forward. The role of the public health practitioner psychologists, GPs will be more important than ever. And I think hopefully the systems will be able to improve to be able to make this a more of a routine part of practice, particularly relating to cancer screening, but also interventions to manage alcohol, unhealthy diets and exercise.
Yeah, that's very important. So from your perspective, Craig, how can we make cancer prevention systems more resilient if the communicable diseases are obviously so important at the moment?
Yeah, look, I do. I mean, going back to your original point, I think it is around system reform is going to be incredibly important. We need the public education to support that system reform. Our screening rates are still less than adequate, particularly for bowel cancer screening. It's around the mid 40s at the moment. We need to be able to utilise the mechanisms that we already have to try and engage as many more people as possible, so that we can maximise the opportunity that if there are cancers, they're detected at an early stage.
Yeah. Okay, great. Well, thank you so much, Craig. That has been really, really an important point, and thank you for bringing the policy perspective into our discussion here. So I now move on to our last speaker for today before we jump into the hopefully lively discussion. So feel free, Joe has asked you all, type your questions into the chat function. I see there's one for Craig there already, but before we come to it, Professor Chris Paul is the co-chair of our Prevention Special Interest Group. And today she also kindly agreed to speak about research. So obviously, Chris is an extremely accomplished researcher, and she heads research at SMPH and is the acting director of the Hunter Research Alliance. And Chris, you've been, of course, researching, being a very active behavioral researcher for many, many years to prevent cancer. And so, for example, one of your very active research agendas is on smoking cessation interventions. So can you speak a little bit about how COVID has, in your experience, impacted your research or research in general? And given the previous discussions, what can we do now to use research effectively to improve cancer prevention and screening?
Thanks, Monica. I think the impact on research has been really variable. So if you take smoking cessation research as an example, I'm involved in some studies that are very kind of remote oriented already. So the recruitment is via social media, the intervention is delivered via video counselling or telephone, that kind of thing. And for those kinds of studies, it seems like the impact is relatively minor, whereas other studies, so one I was intending to have up and running at the moment, again, still about smoking cessation, but for people who are diagnosed with cancer. That study, for example, relies on being able to recruit people in those oncology settings. And as you can imagine, that's just not particularly feasible at the moment. So those kinds of studies, some are suspended or delayed, and you see similar things depending on how much face-to-face contact there is that's kind of essential or unavoidable to the project. Those are the ones that are particularly affected. And some are being, the start is delayed or they're being suspended. And I think we're all kind of paddling pretty furiously under the water to think about how can we make them feasible as it becomes clear that it's not as though there's just going to be a 6-month time period and then everything goes back to normal, that we have to really adjust those kind of studies. So I think it's also particularly affecting some studies that are working with vulnerable groups who might have less access to those kinds of online options, or where establishing trust relationships are really important as a first step. So studies with Indigenous populations, for example, might be particularly affected by what COVID's doing. I think the other thing to think about is new research projects where people are devising their plans, perhaps trying to prepare for funding applications. there's a really reduced capacity for various sorts of, I guess, service delivery people and funders who are just not able to engage with the ideas in the way that they might have previously because there's so much else going on. I think it's a real issue of complexity and busyness that people have that's just laid on top of their normal lives. That means research is particularly deprioritized, I guess I would say, and in some settings suspended or delayed, as I said earlier. And I think perhaps what we might be going to see some months and years down the track is that for researchers, the quality that we might have otherwise been able to produce has been affected by COVID, and that might be in terms of the recruitment or response rates that you have, sometimes the degree or the extent of the intervention that you might have been able to deliver. So I think while people are being really innovative and finding workarounds, it has been and will continue to be for a while a bit of a drain on what we can actually produce as researchers.
Mm-hmm. That's a very interesting perspective, Chris. And so I guess the vulnerable populations are a really interesting point, because as you mentioned, digital interventions could be one way to facilitate research participation, but certain groups of the population might be particularly disadvantaged from those modes as well. So how do you think we could maybe overcome that? Is it an area that there should be increased focus on, or?
Well, I think as a few of the speakers, like Amy and Kylie were mentioning earlier, I guess the upside is that where there are digital options, people are moving to those more quickly than they otherwise would, that there's improvements in, particularly for health services, where before you might have to have tried to push a bit to try and have something telehealth related or digitally delivered. That's happening just by matter of necessity now. So I think it helps in that regard, and that people, while particularly older participants are reluctant sometimes to use those options, there's sort of no alternative in some cases, and people are either just coming to grips with it themselves or finding that people are helping them to do that. And certainly I think for some researchers as well, where perhaps it wasn't their first preference, they're by necessity moving to those options.
Yeah, that's really interesting. Thank you, Chris. And I guess coming back to some of the things that Craig said, where Craig reported increasing calls to the quit line. I know you are working a lot with the cancer information services of the cancer councils as well. So can you reflect a little bit on whether prevention and early detection is discussed more now or less, or how those counseling services are faring with regards to calls?
Yeah, look, there certainly has been an increased number of calls. I guess my greatest concern as a result of COVID-19 is going to be around equity, and are we going to are we really going to see a real greater disparity in health outcomes as a result of this experience? Certainly from a Cancer Council perspective, our ability to engage with priority populations, those who are most likely to be disadvantaged, has in fact been hindered significantly. So even our ability to outreach, to encourage participation in screening programs, to spread our prevention messages has been significantly diminished. We've held off on major public education campaigns, largely given to the level of anxiety that's already out there in the broader community. And being in Melbourne myself, there is certainly a very different look, definitely being outside there this morning with everyone with the mask on, and a very different feel in terms of recognising what we're experiencing here in lockdown Mark 2. And this has clearly been exacerbated in communities who are vulnerable, which are now the ones who are more likely getting COVID. So I'm really concerned from a cancer prevention perspective what this experience will have in the longer term in terms of trying to bridge the equity gap that there already is. And I think that's going to be a lot of work for all of us going forward to try and address this.
Monica, can I just add a little bit to that from the of talking to the 13, 11, 20 services, particularly in New South Wales and Victoria, is that in their kind of fairly close monitoring of what happens, those prevention-related calls really dropped off in late February, and then only started to, as Craig was alluding to, without those screening type campaigns, they weren't getting those kinds of calls that they normally would when those campaigns arise. So it really kind of dropped off the radar for people and was only just starting to come back in June, and now is dropping off again. So it's clear from their experiences that it's not front of mind for people in the way it and what they're seeing is that COVID is kind of woven into all of the aspects of the calls that they're receiving, not just about prevention, but about treatment and psycho-oncology type issues. And what they're finding is though the calls are taking longer for people, and that there's a level of kind of anxiety, but also complexity for people. So when you're trying to do something that you don't normally do, like some sort of preventive activity or something screening related, there's this extra background that's there for people. And so that as Craig was saying, that's going to be particularly challenging for people who've got something else going on and might be in a vulnerable group.
Yeah. Mm-hmm. So do you think, Chris, outreach activities then need to be increased if the active calls in drop off? Is outreach activity something that actually needs to be ramped up to overcome all of those issues, and then particularly to those vulnerable groups and people most affected by the anxiety? Is that
I think so. It's not just, I think you're right that there needs to be a more kind of proactive outreach approach that we take, but it's also that sense of how do we do that in a way that recognizes that people have got this extra kind of cognitive and emotional burden to carry, because everybody's got to deal with this. So it's about not just reaching out, but the way that you reach out, that it's in a way that people can take on, yes, I still need to look after my health in a preventive way. That they do still want to, but it's just that bit more complicated.
Yeah.
Monica, just following up from that, there's just a question here on the comments from Tony, and it's a question for Kylie. Evidence shows that people experiencing a mental illness are less likely to screen for cancer. Does general practice have a role in improving this, and what can general practice do if we're thinking about the current COVID situation?
Thanks, Jo. General practice definitely has a role in screening in general, screening for cancer. People with mental health illnesses often has a higher caseload of chronic conditions, so it's very much in the sort of front and centre of general practitioners. When we care for someone with a mental health condition, then we're not caring about only their mental health condition. It is whole person care. It is also care around other illnesses that the patient may have, and also illnesses that we can help the patient to prevent. So if we see someone with a mental health condition, we manage the mental health condition, we manage the other chronic conditions that they may have, whether it be hypertension or type 2 diabetes, and part of the management is prevention of diseases. So it could be cancer prevention if they fulfill the screening criteria. It's also checking how they are generally, so that we do a system screen as well. Checking height, checking weight, so we know the BMI, so we manage the weight. So for someone with a mental health condition, the role of the general practitioner is more important than ever.
Mm.
Yeah. Thank you, Kylie.
There's also just another question on the chat from Amy. For Craig, do you know whether there's been a higher or lower participation in Dry July this year compared to other years?
There's, from my information, there's been a lower participation in Dry July. I think the broader question around community fundraising more broadly and the impact on services which have been out there for cancer patients and other general broader community services are really suffering as a result of COVID-19 because their fundraising income has been substantially reduced. So while Dry July, I think there has been a lower participation, but we're going to see other services which are providing income to the charity sector also, I think, be under a lot of pressure as they see their income dry up at the moment as well.
I'm sorry to hear that, because there's 3 of us here in North Perth who are first-time Dry Julyers to combat the COVID kilos and the COVID drinking. So I was hoping it might be the other way around.
Oh, well, I don't think it's fallen as much as what they had expected. So I think there's some good news in there in the sense they were expecting a lot more, and that's why they introduced those other options, which was the 2-week option, I think a 1-week and 2-week option, because they felt that people weren't going to be able to cope with 4 weeks if they're in isolation, as we are in Victoria at the moment. But so in that respect, I think the data is actually, while there would appear to be a lower reduction, it's certainly much better than what was probably anticipated.
I guess the community spirit has really maybe increased through COVID. So people are coming together more, even if it's online, such as us today. So maybe that's one of the positive effects that have come out of this, that we all recognize how much collaboration and the community and the people around us are important for all of our health.
That's right.
So yeah, I think that you're joining Dry July, Amy, there with your colleagues is a really good example for that. Fantastic effort. Yeah.
Here's another question from Agnes. Do we have data on how social distancing and lockdown have influenced healthy lifestyles with regards to physical exercise and healthy diets? And I also was thinking the same thing. Have we, given we all talk about our COVID bad habits and our comfort eating and our lack of physical activity, is there a role for prevention interventions that counteract some of the community attitudes and negative approaches to health and well-being as a result of COVID? Open to the panel.
And Craig, maybe you can speak to that, because I think Melbourne has been leading in putting up those pop-up bikeways. I'm really curious.
Yes, I mean, I do hope, I mean, as a keen cyclist myself, I mean, there could be some good things coming out of this in terms of priority towards cyclists, and that, I think that will be a legacy, because people will be wanting to be less dependent on public transport way into the future. There certainly isn't any data yet that I'm aware of that is giving us a clear indication on physical activity levels and healthy diets as a result of COVID, but I can't imagine that certainly in terms of physical exercise that's improved, and I think probably people even working and living at home, they're actually probably doing a lot less, even though it seems counterintuitive. So what I am concerned, as I mentioned before, is that these habits, I mean, particularly again in the Melbourne circumstances with lockdown 2.0, these habits will be much harder to unwind as we come out the other end. And so I think this will be something we'll need to look at going forward.
Yeah.
One other quick thing to add is I think it's shown up in that people perhaps couldn't go to gyms and things before, so they're out in public spaces trying to exercise, that we need to have more of those kind of spaces available to people, and that we already know that the availability of a safe, attractive kind of environment does make people want to exercise more and engage with it more. So perhaps that's a bit of an opening to try and encourage the various levels of government to make that more available, like the bike lanes, but more broadly for walking and running and just moving.
Absolutely. I think that's very true, Chris. So thank you everyone for the very active discussion there. I think we've heard about the cancer preventive agenda from a variety of perspectives today, including the I guess the research side, the practical side, the clinician side, and the policy side. And it seems as if there's a whole research agenda evolving just out of this one webinar. So I'm very grateful for all of you to join today. And luckily we've recorded it so that we can look back at all of those interesting questions that were raised. And so without further ado, can I pass on maybe to Joe to say a few concluding words from PoCoG?
I'd just like to really thank the Prevention Special Interest Chairs, Monica and Chris, and all our panelists for what has been a really interesting and insightful webinar. I'd encourage people to actively engage with the Special Interest Group, because you can see there is quite a large research agenda and opportunities that probably unexpectedly have come from COVID. And if you're not a member, all you need to do is contact the PoCoG Executive Office via email, and we can sign you up for the group. And moving forward, the group will hold a teleconference or webinar to try and capture some of these great ideas and try and cohesively move forward to try and address some of the issues that have arisen. So I'd just really like to thank Monica and Chris for a great webinar.
And thanks to the speakers. Thank you very much for taking the
Thanks,
time
everyone.
out of busy schedules.
Thanks.
So, bye, everyone.
Bye-bye.
Bye.
Thank you.
Thanks.